Hi, my name is David VanSickle. I'm a neurosurgeon here at Littleton Adventist Hospital. I'd like to talk to you today about a new procedure doing deep brain stimulation asleep rather than awake. We've been doing deep brain stimulation for many years, and I myself have been doing it for 7 years. However, today we'd like to focus on a new way to do it where you don't have to be awake during the procedure. One of the things I want to talk about is the rapid pace of information which has come for using DBS with individuals with Parkinson's disease. DBS is FDA approved to treat the symptoms of Parkinson's disease and has been since 2002. Many people still feel that it's experimental, it's something that's up and coming, but it really is here and now. And the information which has been coming out about the benefits from deep brain stimulation has truly been dramatic and rapid. In 2001, the VA study group demonstrated that DBS was both safe and effective. The FDA approved DBS based on that study in 2002. That was only 11 years ago. Now we know, as discovered by Deutschel in 2006, DBS is effective in a randomized controlled study. Randomized controlled studies is what we doctors look for as the best medical evidence about what to do to treat our patients. These randomized control studies have been repeated multiple times for DBS, and in 2009, DBS was shown to be superior to using just medications alone. In 2010, we learned by Dr. Follett that in a comparison between different targets, the subthalamic nucleus and the globus pallidus internus, that these targets are relatively equivalent. So no matter which target your center uses, you're likely to see benefit. In 2010, Dr. Williams demonstrated that DBS plus good aggressive medical management was better than medical management alone, also through a randomized controlled study. It's really important to point out that we understand DBS works through these randomized controlled studies better than we know much of the rest of medicine we practice. And recently, in 2013, Deutschel published that really we should be doing DBS earlier in the disease, at the first signs of motor fluctuation. The same benefits that patients received in those earlier studies can be had to an even greater degree for individuals who were implanted potentially in their first 3 to 4 years after their diagnosis. Also, we learned in 2013, just literally several weeks before this clip was filmed, that DBS can potentially extend the lifespan of somebody with Parkinson's disease. The reason for that, in a study performed in England, in Birmingham, after a 10-year follow-up, was that those individuals who had deep brain stimulation seemed to not develop the swallowing problems leading to aspiration pneumonia that did develop in individuals who didn't get deep brain stimulation. This really came as a surprise to all of us who worked in the field. We always thought deep brain stimulation was simply for treating the symptoms. Now we know it may actually extend lifespans. Randomized control studies are the best form of evidence. As far as extending lifespans, however, we probably won't see a randomized control study. Once you know that you could potentially extend somebody's lifespan with it, you can't ethically perform such a study. So you might be wondering whether you're a candidate for deep brain stimulation to treat your symptoms of Parkinson's disease. The candidacy is fairly straightforward. First thing is you actually have to have idiopathic Parkinson's disease. That might seem fairly obvious, but there are actually other forms of Parkinson's disease called Parkinson plus syndromes. And we want to make sure that you don't have one of those diseases. Only a neurologist or a neurosurgeon can be able to tell for sure. Other things are that you want to make sure you respond to a drug called Sinemet or one of the sister drugs that is like Sinemet. While it's important that you have some response to Sinemet or one of the sister drugs to Sinemet, your tremor does not necessarily have to respond. It's also important to know that you only have to have a little response to Sinemet. Some individuals can't tolerate Sinemet at all. It makes them sick. And in those individuals, I often will have them try just a little bit, just to see that they have a response. But even a little bit of response is sufficient. With that, we talk about a window of opportunity. Probably when you're first diagnosed, the first day, you're not ready to go off and have brain surgery. And likely your symptoms will be well controlled with just a few pills. However, late in the disease, when contractures in the muscles have set in or dementia has set in, the deep brain stimulation is not likely to improve your quality of life. It's in that middle area, and we're tending towards earlier in that middle area where deep brain stimulation is most effective. One good way to think about deep brain stimulation is, as far as quality of life, is it will back up your quality of life to where it was about 7 years ago. So you think about where you are today and where you were 7 years ago, and that's a pretty good prediction as to where you'll be after deep brain stimulation. Now, every patient's a little bit different. Some actually back up more than 7 years, some back up less. But another way to think about it is, I know the way I am today, and I see where I'm going to be in 7 years. Would I like to be like I am now in 7 years rather than where I'm going to be? DBS treats the motor symptoms of Parkinson's disease. It treats the slowness of movement. It treats the shuffling gait, where you walk stooped forward. It allows you to stand upright. It treats tremor. If you have a tremor from Parkinson's disease, DBS is very effective at reducing it or potentially eliminating it. It treats the masked face, where you can't express yourself to others and to loved ones as you once did. Many times my patients tell me, my patient spouses tell me, thank you for giving my spouse back, because the expression is like it was 7 to 10 years ago. It does not typically treat the non-motor symptoms of Parkinson's disease. These symptoms are blood pressure drops when you stand up. If you have significant balance problems, those symptoms typically are not treated. Only a neurologist or neurosurgeon can tell you for sure. But like we talked about, with the very fast advancing pace of information concerning deep brain stimulation, it's important to seek out someone who's up to date on the most current information. I'm often asked about the success rate of deep brain stimulation. It's a bit of a hard question to answer because most individuals don't think I'm being honest. I actually have not yet had a patient who said they wouldn't do it again. Really, anecdotally, I can divide my patients with deep brain stimulation into two groups. There's the younger, healthier group who do it early, and oftentimes it's almost as if a miracle had happened where they look like they don't have the disease. There's my older patients who typically are just a lot better, but they really still have some symptoms of the disease. I haven't yet had the patient that is worse off than they were before. That being said, deep brain stimulation is not without risk. There are two main risks that are important to talk about and to understand to put them into context. One could have a stroke from this surgery, but realistically, the risk of that is approximately 1 in 1,000. One could have an infection from the operation. However, realistically, while the system might have to be removed and redone, which is an absolute terrible inconvenience for the patient, nevertheless, usually in the end, we can still get a good quality outcome. These are the real risks of deep brain stimulation. Oftentimes, when an individual talks to their spouse or their other loved ones or to sometimes uninformed physicians, these risks get overblown. And I think it's important to just address them head on as to what the risks actually are. So it seems intuitively obvious, but one might wonder why you'd want to have deep brain stimulation asleep versus awake. I actually offer both surgeries still to this day. More than 100,000 electrodes, actually more than 100,000 patients have been treated with DBS. The vast majority of those patients have had their leads placed during an awake surgery. Those patients have done very well. We have a lot of information about those individuals, and we know the risks very, very well. Asleep DBS is new. There's only about 5 of us that I know of in the United States that are performing this operation. It has probably some risks that we don't even know about because less than 1,000 individuals have been treated in this way. However, I give the same explanation to all my patients, and 70% choose to have it asleep simply because it is more convenient for them, it is less scary for them, and there's less discomfort associated with the operation. If the electrode is placed within the intended anatomic target region within about 1 millimeter of air, individuals will typically have a very good response. If it's outside of 2 millimeters of air, individuals likely won't have a good response at all. In the past, our MRIs have been accurate to approximately 2 millimeters or so. We have to compensate for that inaccuracy by another method to augment it. Traditionally, during awake surgery, we use microelectrodes. These microelectrodes have tips on them that are so small, they're about 1/4 millimeter in diameter, that they can record the firing of single cells within the brain. That firing pattern is how we confirm we're in the right location. We also confirm we're in the right location by stimulating both with the permanent electrode, and this is an actual permanent electrode that would be implanted, as well as using the microelectrode to confirm that the slowness of movement, the rigidity, and the tremor do indeed stop. Now, I can't simply hold one of these freehand. I need a way to hold it because the accuracy would be far beyond what I could do with my hands. I use a platform like this called a Starfix platform, but others around the country might use a frame which goes around the head or other similar devices. Because the electrodes have to be advanced very carefully, a little drive like this is attached to the platform on the patient's head to, in hundredths of a millimeter at a time increments, advance the catheters through the brain to the target area. All of this happens with the patient awake and is necessary for them to be awake so that we can determine the right location and correct for that 2 millimeters of air. A new method is to just simply place a surrogate for the electrode. We'll place a probe where we think the electrode should be, and then use a CAT scanner to actually look inside the brain and confirm where that electrode tip is. This is a Serotonin CAT scanner. It's a type of an intraoperative CAT scanner that is highly accurate, and we can take the images from this, fuse them with our MRI hand in hand so they become one image, and see where the tip of our stylus is in the space of our MRI, thereby confirming its location. It's a different way to achieve the same thing. On the one hand, we can confirm the functional location of the electrode by confirming its use. On the other hand, we can confirm the anatomic location of the electrode within the space on the MRI. Because the anatomic location does not require the patient to be responsive to us, the patient can be under general anesthesia. Being under general anesthesia allows the operation then to proceed much more quickly because we don't have the trial and error aspect that's associated with the awake surgery techniques. The MRI shows us our intended target. The CT shows us where our electrode is in space. By putting those two images together, now we can see our electrode in the space of our MRI. Those images need to be fused together and are done by using a computer. This image shows just the CT with the MRI blended away. The CT's been adjusted to show only the electrode, which is a significantly denser object than the brain. And the yellow shows us our intended trajectory, with this trajectory looking right down the axis of the trajectory, kind of like a bullseye or a target. This is the MRI from which we obtained our ideal trajectory from. The subthalamic nucleus in this particular case can be seen as a black smudge, looks just like that around that area. And we can see related nuclei, including the red nucleus, which is near it. It's by putting the two images together that we see our electrode is indeed in the intended area. The MRI we obtain for our sleep DBS technique is significantly more accurate than our awake MRIs. The reason for that is the patient doesn't move at all during the MRI. Also, the MRI can take place over a longer period of time, improving the signal-to-noise ratio and thereby improving the accuracy. That's one of the keys to allowing us to do a sleep DBS and use the images to verify where the electrode is. But more importantly than that, it allows us to encapsulate many aspects of the procedure into one procedure. The pre-op imaging, the planning, and the actual placement of the electrodes all take place in one 3-hour period where the patient goes to sleep and wakes up and the electrodes have been completely implanted. All that's left to do at that point is to put in the generators and program the device so that individuals see the benefit. After the electrodes have been implanted, whether asleep or awake, the electrodes are activated using a DBS pulse generator. These generators use technology similar to that of a pacemaker. They can be implanted in several locations, but are typically implanted in the chest approximately here. Oftentimes, one generator is used for each side, and that's the preferred way that we do it here in Denver. However, sometimes, especially if a person has a pacemaker on the other side, one generator can be used for both sides. As you can see, it's somewhat of a bigger, thicker generator, which is why I don't prefer it, but it can be a good option for some individuals. Programming is typically performed immediately after the generators have been placed. If an individual is older and has maybe some additional medical problems, oftentimes we do programming in a rehab setting. But as the trend is moving towards younger patients, oftentimes these younger individuals simply can be programmed as an outpatient, starting to have the benefits and getting on with their lives. While the initial programming is the most important programming, oftentimes over time with Parkinson's disease, symptoms can progress. But given that this is a programmable device, the device can be reprogrammed over time to provide additional benefit should your symptoms increase. Batteries last typically 3 to 5 years. After that, they need to be replaced. Fortunately, that can be done in a 15-minute operation where you can leave the same day. There is actually a rechargeable battery where the battery can be replaced only once every 9 years. It's not for everyone because it typically has to be recharged every day. Once the battery is placed, the most important programming is the initial programming. However, your Parkinson's disease may progress with time and may require additional programming. That can be done oftentimes by a local neurologist. Traditionally, where an electrode is placed in basically a single operating day over oftentimes 5, 6, or 7 hours, only to have a patient come back and put another electrode in over an additional 5, 6, 7 hours, is extremely uncomfortable for the patients. It is also extremely expensive for society. At that pace, a typical surgeon can only put in a limited number of electrodes in a given year. That means that many individuals who have Parkinson's disease, who by the latest evidence could benefit from deep brain stimulation, will never benefit from deep brain stimulation unless we change the way we do it. Having a new technique available which is as good as the technique which we've done for a number of years, but which can be done less expensively and can be done more efficiently, will allow the surgery to be brought to far more individuals. At the present time, I offer both surgeries in my practice. I do the surgery awake and I do the surgery asleep, and my patients choose which they'd rather have for them. Many of my rural patients, however, are choosing a sleep DBS not because they're afraid of awake surgery, but simply because it's far less trips to Denver they have to make. We talked about the fact that it improves your quality of life by reducing the rigidity, it reduces the tremor, it reduces the painful cramps oftentimes associated with Parkinson's disease. It allows you to express yourself better to your loved ones. We talked about why a sleep DBS might be better for you than having DBS awake, simply by making it more approachable, allowing individuals who would never consider having an awake surgery to actually have the benefits of deep brain stimulation. We also talked about the potential benefits to society by allowing more people at large to have the procedure. But ultimately, this is your disease, and you're the one that has to live with the problems associated with it. I would strongly encourage you to do the research about the latest information that's available for yourself, and to do the research about the latest techniques available for yourself, so that you can make an informed decision moving forward as to who you want helping take care of you and how you want to live your life. I'm Dr. David VanSickle. Thank you for listening. I hope this information has been helpful for you. Thank you.